Okay, when we are looking at chronic kidney disease, okay, so I know that how the concept there made it that acute kidney disease you will be learning into your next semester. Okay, so here we will be majority of the time we'll be talking about the chronic kidney disease. Chronic kidney disease is like a COPD. Okay, it's a slow progression person goes into. It's like a slow progression in the decline in your renal function. The renal function, we usually look at your glomerular filtration rate. Filtering for the waste is the main function of the kidney. And it's done with your Bowman capsule with all those nephrons. Okay? So that rate decides how functional the kidneys are. So you'll be feeling in the renal function a lot of GFR, blood urea nitrogen, creatinine. Okay? So here that's what we'll be talking about. So this is just like a review for your anatomy. Okay, you need to know this in order to be able to understand the concept of chronic kidney disease. So that's what usually your kidney does. Unfiltered goes, okay, then filtered goes, whatever the waste is goes into the urine. So main is like a filtration. Okay. So these are some of the things that can put you at the risk for chronic kidney disease. When we talk about our primary prevention, we talk about preventing all these, so you can prevent chronic kidney disease. So also look at these, some of the questions when you try to prepare, like get the better, deeper understanding, how the kidneys and the kidney function test and fluid and volume and hyperkalemia and hyperphosphatemia, they're all related. Just look at these, some of these questions. So these are all from your anatomy physiology. Okay. And we are going to talk about this as we go. So this is just an overview. So why it's important to know? Because in US they make those healthy people goals that where they focus on a one problem or two problems every 4 to 5 years. So chronic kidney disease was one of the healthy 2020 people goals. Okay. So acute injury. So give me some of the causes where a person can have acute renal failure. Some of the causes that can cause acute renal failure, not chronic. Severe dehydration, trauma, alcohol. Like where you are losing blood or your kidneys are not getting proper perfusion. Okay? Your kidneys are getting impaired perfusion, all those conditions can cause acute. Somebody lost too much blood. Somebody's dehydrated for a longer time. Okay? Acute, what is the thing? Acute, you can fix it for a minute, then you can reverse it. Okay? Once you reverse the cause, it can reverse it. Chronic, it's irreversible. You cannot go back to the no function that you were before. Okay, so that's another difference in there. And usually chronic, it progresses for years as unrecognized sometimes. The final phase, we call it as a end-stage renal disease. Okay? That's where your glomerular filtration rate is probably from 10 to 15% only. Okay? 80 and above is considered normal. Okay? So 80% and above. So, but even if you start saying slowly, stage 1, stage 2, so your functions start decreasing as you go. And here, like we said, little, 10 to 15% is not that much. And around this phase, they start making the decisions regarding putting them on a transplant list, okay? And also sometimes start with some end-of-life care or palliative care. You know that because it's going to get worse unless you replace the kidney. So this is how it progresses, okay? How it kind of goes into a fully blown renal failure. Okay? It's gradual, not acute, okay? Person is getting impaired kidney perfusion, not just like a quickly that we can see a person lost a lot of blood. okay, or person is under trauma or injury, or person is clearly dehydrated, that kidney is not getting perfused. Okay? So those are some acute conditions. Here is a slow gradual. Okay, you can see that. Then proteinuria. But it's not filtering. Kidney is supposed to filter, the bigger molecule is supposed to go back. Okay? But here the proteins are coming through and they are damaging. Okay? So decreased renal reserve. So GFR is probably around 50% here. And renal insufficiency, when there's a renal insufficiency, person can start having high blood pressure, infections, dehydration, nephrotoxin, or obstruction. Then you can go into a fully blown like a renal failure. So that's what we look at. Your non-fatty will be high. Person here will have oliguria, and they will have more blood urea nitrogen. That will be high because the waste is supposed to be eliminated, but since the kidney function is disturbed, so you are collecting that urea in the blood. So this is just the incidence. So these kind of a question help you to decide which person is at the high risk. Always look at the age, the race, the gender, and any other factors that puts them at the risk. Okay? Here, like we talk about, 4 times higher in African American. It's like a genetic makeup that puts them at more risk for kidney disease. Okay? And the high incidence also minority population too. But this is probably the lack of access to the health care. And hypertension and diabetes are also more in African American and Native American. So this population puts them at a lower risk. So these are some of the causes. When we look at the causes, there might be some direct causes that like there's a direct injury to the kidney or something happening to the kidney itself, or they're taking some nephrotoxic drugs. Sometimes it can be a fluid volume deficit or something that's not related directly to kidney. So that's why you're seeing it. Diabetes can do that too. Okay? What does diabetes do? How does it affect the kidneys? Remember hyperglycemia? Constant high blood sugar. Your sugar should not be filtering through the kidneys. When you have high, it start damaging your the other thing is diabetes also hardens your arteries. Uncontrolled blood sugar can give you hypertension. Eventually, it affects the perfusion for your kidneys. Same thing, diabetic nephropathy, that's what we call it. Any kidney failure that's related to or because of diabetes, we call it a diabetic nephropathy. Hypertensive nephrosclerosis, glomerular, these are the things that happens in the kidney itself. Somebody has an infection in the glomerular, okay, or in the pelvic of the kidney, pyelonephritis, okay, or polycystic kidney. They all put you at the risk for renal failure because kidneys are not functioning properly. Systemic lupus, SLE is another disease, okay. It has not to do directly with kidney, but it's a multi-organ. As it progresses, it also affects your kidneys too, your brain, your heart, your lungs, your skin, okay. So it's like an autoimmune disease. Some medications, penicillin, cephalosporin, lysins, NSAIDs, diuretics. So remember, the way you collect fluid in there, it affects your kidney function. Whenever we talk about Tylenol or acetaminophen, we are worried about liver. When you talk about Advil, Aleve, naproxen, Toradol, NSAIDs, we're worried about the kidneys. Okay? So keep those in mind. Snake venom, amphetamines, cocaine, that do affect your kidneys. Then environmental, lead, cadmium, mercury, and chromium. You might have some chronic renal failure patients that working in those industries for 30 years. Okay? So if they are in the end-stage renal disease, they are having hard time getting on a transport list, they might have to make some hard decision to leave that industry. Okay? So those are the things that's what we need to know. Okay? So this is how the stages look like. Stage 1, 2, 3, 4, 5. So it's more than or equal to 90, not 80. Okay, so more than or equal to 90, so it's supposed to be normal. From 60 to 89, stage 2. Okay, so GFR 30 to 53, then 4. So look at it here, it's like very less. So right here you start preparing for the dialysis or for the renal transplant. So that's how the stages are for the chronic kidney disease. Okay. Why these stages are important? Because it prepares you for the next stage and how can prevent that stage and how can deal with those complications. Okay. Prevention, this is a prevention. You see that here. What are we trying to prevent? Diabetes, okay, or the hypertension. So these are some of the important things that we want to avoid, especially if the person is at the risk of developing those diseases. If somebody has a family history of diabetes, somebody has a family history of hypertension, so we start doing education in your primary prevention. Avoid smoking and all that. Tell them if they are at the risk of developing, they need to monitor their intake output and look at the urine. Okay. So like Nisha mentioned about the dehydration. Okay, so they need to know if they're getting too dehydrated. The urine can tell the urine color. Very important for them to have an annual physical done with the provider if you are at the risk for developing any disease. Over the counter, okay? Any medication that's over the counter, they take it, they need to be very careful about that too. Like an NSAIDs, that's some number one. Clinical manifestation. So we know that if you have a person who is in a chronic kidney disease, their blood creatinine and GFR will be abnormal. We know that. What else as a nursing assessment you're going to find in that patient? Okay. Nausea, vomiting, apathy. So these are some of the symptoms that you see it. We know that nausea, vomiting, confusion, that's because of accumulation of waste product in the body, especially related to urea. Okay. And you might see in some patients that urea skin, if you get a chance to see a dialysis patient, you can see that their skin also looks like a calcium deposit. It's like very dry, very like a white residue on it. So it's because of urea. Look at that. It affects every system. Okay, if we start with the kidneys. So just kind of look at it and see how it affects the uremia. Once it gets to uremia, like you have too high of blood urea, nitrogen. So then it starts affecting all organs. So here we know that we are not going to cure this person. Okay, there is no cure because it's irreversible. It is going to proceed. Only thing we can do is delay going from one stage to the other stage a little bit longer, give a little bit longer time by proper treatment, treating the complications, and prepare them for renal replacement therapies. When we talk about renal replacement therapies, in the stage 4 of the end stage, we talk about the dialysis and also renal transplant. Okay? When we talk about the dialysis, it can be a peritoneal dialysis, it can be a hemodialysis. So those are the three things that we talk. These are some of the diagnostic tests that we need to do it. So all these will tell us that there is something going on with the kidney. Okay? Renal sonography, kidney biopsy will tell if there is something wrong in the kidney itself. It will give you the cause. The other thing is pharmacology. When we talk about, we are not only treating it with the drugs, but we are also being careful what drugs the patient can take. You might have to change because the drugs are not getting excreted through the kidney. They are getting accumulated in the body. You might have to decrease the dose for the patient who have impaired renal function. Okay, one example I can give you, the morphine. Okay, if I have to give morphine to Ashley, okay, I will give her 4 milligrams. I know that her liver function is good, her kidney function is good, is going to metabolize and come down. But if she has a kidney disease, I might have to give her 2 milligrams because it will accumulate, the metabolites accumulates in your body and you will see the sedation effect for longer. Okay. So that's another thing we have to look at the pharmacokinetics and the pharmacodynamics of the body work. The other thing is protein-bound drugs may lead to toxicity. Okay, you have too much protein, okay, or in the urine. when you have too much protein in the urine, you have less protein in the blood. So the drugs has less protein to bind it to. So where the drugs will end up in the blood. So you will have more toxicity. Okay, because they are not binding with the protein, but they are circulating in the blood. So that's why they can cause more toxicity. Nephrotoxic drugs, gentamicin, vancomycin, digoxin, some of the seizure medication, and NSAIDs. Those are all bad for your kidneys. So that you have to tell them to stop it when they have it. Avoid drugs eliminated by the kidneys, especially if person has a very low kidney function, you're not going to give them any diuretics. You only give diuretics if there is a kidney function. Because you know that diuretics is only going to work if your kidneys are working. If they're not, then instead of helping them, you're putting more. There's the angiotensin converting enzyme inhibitors. So you have to be very careful about that too, because they work on the renal system. Okay, they put more load on your kidneys. Because this one is all kidney, your angiotensin is converted. This is enzyme that's coming from your kidneys. The other things, the person will have hyperkalemia. So we are going to go back to your fluid electrolyte hyperkalemia interventions. So we are going to use all the intervention that we use in hyperkalemia. If somebody is in a hyperanemia. The other thing is, they don't have the capacity to build the red blood cells. They can get anemia. So that's why these are the two medications that can be used to build up your red blood cells. It's the epoetin and darbepoetin. Okay? And the iron supplements are the other one that can be used. Okay? For uremia, you can use diuretics if there is a kidney function, not in the end-stage renal disease. You have to have some kidney function in order to give the diuretics. Hypertension drugs, dyslipidemia, because all these can cause problems, okay? And you're going to treat them. Mineral and bone disorder, that's what I was talking about in hyperphosphatemia. This person will have high phosphorus. We are going to use calcium carbonate and calcium acetate. You call them phosphols. They bind with the phosphate, okay? Then they decrease blood phosphate level. Okay? So that's what these medications are used. Two of them are calcium-based. Then you have two non-calcium. I think I have seen the phosrenol used a lot, and phosphol. These are the two I have seen used a lot. So you will see in the hospital if you go to those two. Both of them, whether it's a calcium-based or non-calcium, their work is to bind the phosphate. When they bind it, they get bind with the calcium phosphate, and then they are not freely flowing in the blood. So that's how they collect hyperphosphatemia. You're also going to give calcium, vitamin D, because if a person has a hyperphosphatemia, they will have low calcium. Okay? You guys okay? Here's something. So then the dietary modification. I want you to keep in mind, in the normal kidney disease, if somebody is going through the stages of the kidney disease, okay, they will have hyperkalemia, okay, they will have hyperphosphatemia, okay, they might have proteinuria. So in those conditions, we are going to tell them low potassium, low phosphorus, okay, and low protein diet, okay, in that condition. But if your patient is on dialysis, your peritoneal dialysis or their hemodialysis, you want to give them high protein diet. Remember that if you have questions that says person is on a peritoneal dialysis, what diet? High protein. Okay? If they are not on any kind of dialysis but they have a renal disease, that's where we do the low protein. So salt substitute, we watch it, high phosphorus food. So this is mostly the diet look like. If somebody is a pre-end stage renal disease, like this person is not on a dialysis. Okay? Here we see that we don't give that much protein. Okay? Sodium is also 1 to 3 grams. Okay? Potassium is based on the values. If it's a hyper, you want to do the low potassium. If it's a hyperphosphatemia, low phosphate, this one depends on what is the level of their electrolytes. We want to do the calcium, we want to do the iron, okay, because they can have anemia that's related to your renal disease. But here in both dialysis, you see that we're giving high protein as compared to this. Okay. So these are all, whenever somebody's on a dialysis, how much fluid goes in, how much comes out, or what type of fluid you want to use for dialysis to filter it, it depends on their lab value. Or how long they need to be. So they all make decisions based on your BUN, creatinine, potassium, and phosphorus, like how much you need to take them out. So dialysis, peritoneal and hemodialysis. Peritoneal dialysis, what is the benefit of it? Patient can do it at home too. I have seen a lot of peritoneal dialysis done, okay, I think earlier. And I worked at Presby Dallas in 1999. I have done few over there, but I have never seen any in Baylor. That was in 2005. So you see that how it starts decreasing. Okay, you rarely see it, if you see it, but the nurses need to know what the peritoneal dialysis is. The hemodialysis is more common, we all know that. Okay. So in the end stage renal disease, they have to go 3 times. They either go Tuesday, Thursday, Saturday, or they go Monday, Wednesday, Friday. Okay. So it's a 3-time total of 9 to 12 hours in a week. Renal transplant is a donor kidney, so that's another renal replacement therapy. What is the goal? To keep the fluid and electrolyte balance. Okay, that's the goal. And body weight within normal limits. Normal vital signs, normal skin. So that's what we want to look at your positive outcomes. That's what we want to have it here. That's our goal. That's what we are doing dialysis therapy, whether it's a hemodialysis or it's a peritoneal dialysis. Okay. This is a hemodialysis. Hemodialysis, you know that there's a machine and there is this little, we call it a dialyzer. Okay. So this works as a kidney. This is the one that filters. Okay. You just need an extra filter thing. That's what we're doing with the hemodialysis. So the other thing you see that there's a connection. You have one artery, one vein, so they're connected. The blood goes, gets filtered, and goes back in the body. Okay, so that's what is happening. There's a blood pump, it goes over here, the blood flows through the dialyzer. Now this is a solution that helps with the filtration. Okay, then this is another one. So heparin, that's very important. Whenever somebody's on dialysis, they are at the risk for hypercoagulation. So that's why the doctor will order some units of heparin to go with it too, so the blood does not coagulate. So these are some of the complications from hemodialysis. Okay, the first one we all know that, because you know when you do your calculation how much fluid need to go in, how much need to come out, we are just doing based on the body weight. They have to weigh daily when they go for dialysis. They also are based on your fluid and electrolyte in the body, like your how much electrolytes are. And you can easily sometimes take too much. If you take too much out of it, so you can put the risk for hypertension. Muscle cramps. If we drain too much electrolytes, okay? Our goal is we are trying to get rid of potassium and phosphorus, but you know that sodium, magnesium, calcium, they can all be gone through the blood. So muscle cramps, you can lose blood too. The bleeding can happen because you are accessing the arterial. Okay. Hepatitis. So especially the one that's a blood-borne. Dialysis is the blood is circulating outside. It puts you at the risk for hepatitis that's a blood-borne. Okay. Which one is it by the blood? A, B, C. I think it's a B and C both. A is a foodborne, so that's from the food and water. B and C can be a blood. Okay. So now we're talking about access. So you probably heard the AV shunt, AV fistula, central venous catheter. Okay. So those are the 3 different ones. This is the very fairly new. Okay, where they implanted is inside you. Have you anybody works in oncology floor with the port? They put a port into one of your veins so you can access it. Okay, so same thing. That's how this one works. Okay, they implant it in there. So when person has to go, it goes into your arm directly here. So when you have to access it, you can just put the needles in there and access it and do the dialysis. So it's called as a hero graft. Okay. So this is a fairly new. I have never seen any patient because I have not been to the hospital probably since 20 something, 11 or 12. So, but I have heard from the students that they have seen on very few patients these ones. I think you need insurance approval for that. Common ones are these. You will see atriovenous fistula. If you know that somebody is going to be on a long-term, it's a chronic kidney disease, okay, they have to be on hemodialysis, so they create a connection between artery and a vein. That's what fistula is, okay, creating a hole. Here it is, okay. And graft is you create a connection, but you put a loop, extra loop. It's not directly connected, but they're connected to a loop. Okay? This is an AV graft. When we say an AV graft, it's an atriovenous. You are creating a connection between artery and a vein. Okay? In a graft, there is a loop. In a fistula, there is a direct connection. They cut it and then stitches together. Okay? So why it's important as nurses, if you have a patient who has AV graft or AV fistula, there is a different assessment you're going to do it. Okay? Just like we assess any IV site, we have to assess these too. Okay? So this one is your venous access. That's a central. It goes directly into your superior vena cava. Then it goes to your right atrium. So this is the two loops. Okay. So that's how your blood gets circulated to those. So you will see these more common in an acute kidney disease. Okay. In acute kidney disease, we know that it's not for longer time period, so you can use that too. So this is how it looks like. This person is in ICU or this one is in a dialysis. So one it's going and it's filtering, then going back. So it's a central venous access. So how are we going to care if the person is coming with the graft or the fistula? So the nurse should assess patency of the AV fistula and graft by assessing fluid. Okay, how do you assess? You put your hand over it and you feel that vibration under your hand. You call it a bruit. Okay? No, you call it a thrill. Then the bruit, you listen with the stethoscope. Okay, if you put it here, you see that sound. Go on a YouTube. I don't know which one was that. It will tell you like what kind of voice you will hear in the auscultation. Okay, they have like an amplifier in one of the videos. I'll see if I can find it. So very important nursing assessment. You have to do it every 8 hours. Okay, look for the presence of bruit and thrill. Okay, and the other thing is assess for bleeding, especially after it's accessed. Person comes from the dialysis. You want to make sure the pressure they're seeing is on at least for 4 to 8 hours, and you're going to monitor for signs and symptoms of bleeding and looking at any infection. So these are some other nursing intervention that you need to be doing if you have a person who has AV fistula or AV graft. Number one, put a sign at the bedside, no blood draws, no blood pressure taken from their arm, okay? Because you can actually rupture it or monitor for these signs and symptoms. Teach patient not to lie on that extremity. You can actually cut off the blood, okay? And teach them how to care for fistula. Normally, when it's a new one, you all give them same instruction you give for any surgery. Like watch for signs and symptoms of infection, don't touch with bare hands. If the doctor put the dressing, do the dressing, otherwise they don't need to be. Okay? So just your regular skin tissue integrity teaching. Okay? They need to have alert hairband too, so they need to know okay, that they have a fistula or they have artery in case they get picked up with the ambulance or something. They know it where not to stick. Peritoneal dialysis. In the hemodialysis, we have a machine, okay, where you call it like you have a kidney that's outside. It's like a machine, mechanic kidney, okay. In a peritoneal, your peritoneal cavity acts like a kidney, okay. We use the peritoneal space. If you see it here, the peritoneal space is acting like as a filter, so it helps with filtering. You have a question, Jenna? Okay. So this helps with the filtration. It's the same same thing, you know, it goes, there's a catheter, okay, it's just like your PEG tube, your gastric tube, the one we use for feeding. So it looks like that. Then there's a little soaker hose, that's where the fluid goes in, then it cleans out and comes out from the. Here you see that there's no blood circulating. We're just putting a dialysis solution in the peritoneum. We lock it, let it stay. We have orders. How much to put, how much to hold, and how much to drain. Okay, those are the orders come from your nephrologist. So after you held it for a while, then you drain it. Okay, so that's how the peritoneal dialysis works, and that's how the patients can do it at home. Okay? Because it has nothing to do with blood. So that's how the patient look like when they do it. Okay, remember, look at that, their head's supposed to be up. And this is the dialysis solution. It goes in. Okay. Once it goes in, you clamp it, so just stay it for a while. Then you clamp it here and let it drain. This is the drainage bag. Okay. So this is like a filtration process. You're getting waste and using peritoneum as a filtration. Some of the complication, I want you to think about where the catheter goes. Okay. Site of infection, because there is a hole in the skin integrity. Peritonitis is the number one that we have to keep in mind. Okay? Signs and symptoms of cloudy. If the solution is turning cloudy or nasty, that means there is a peritonitis. There's a pus or blood or something going on in there. Nausea, vomiting, fever, these are all your abdominal. Okay? When we say abdominal pain, we can have abdominal pain in any condition. Okay? This pain is rigid, band-like. You know, peritoneum covers your whole abdominal cavity. So it's like full rigid stomach. You feel like it comes in bands because it comes from one side to the other side. So it's a band-like abdominal pain. So here aggressive antibiotic is required. If you don't treat it, it can lead to hernias, okay? Lower back problems, bleeding, pulmonary complications, protein loss. So you have to watch for all those. So now the kidney transplant. We won't go much detail in the kidney transplant. As far as the kidney transplant, I just want you to know what is the pre-operative care, just a regular, during and after. Okay, just a nursing intervention. You don't need to go more detail because this is discussed, I think, in acute renal failure sometimes. Okay, so but just focus on your pre, post, intra, and post care. So this diagram, you see that this is a diseased kidney, and then this is a new kidney that goes into the powders. Okay, they take it out, they can put it in the same place too. The other thing you need to remember, they keep the adrenal glands. They don't remove them. Okay? Adrenal glands are the same. What they replaces is the kidney. Kidney with kidney. So the other thing is when somebody has a renal transplant, you have a patient. Remember, we can have a patient with a renal transplant coming with pneumonia. So now you see that how our concepts overlap. You have a patient, he has a renal transplant, now he showed up in the hospital with pneumonia. So you have to watch for, they might be on immunosuppressant agents. Okay? Because what do? Prevent kidney rejection. Okay? How do our body reject? Through the immune system. Our immune system is the one that tags, this is foreign, this is mine, this is foreign. Okay? So you want to reduce the immune system because you don't want it to be tagged in the kidney, even if it's a little bit different. Okay? Glucocorticosteroids, they also suppress your system. You might see them on a prednisone. Okay? So think about that. You have a patient who has pneumonia and he has a kidney transplant. You might be on immunosuppressant drugs and steroids that increase your risk for infection more. Okay? So those are some of the things that we need to keep in mind when we take care of patients and what medication they are or how your care changes if somebody has a renal transplant. So these are some of the things that we have to look for the kidney rejection. Acute can happen within a month, but if it doesn't happen, chronic can happen any time in the week. So you cannot, that's why some of the patients, they have to stay on those anti-rejection drugs for the rest of their life, okay? Because there is no time frame for this. So have from your kidney too. Okay, they can have hypertension, infection, tumors, okay, risk of congenital abnormalities in children of women who undergone immunosuppressive therapy. So now you see that how this thing changes our care of a female who has a renal transplant and she's pregnant. So she requires more monitoring. She requires more sonograms to monitor the baby for any congenital problems. So this is we can review this will tell you how the kidney transplant is done. But just focus on your pre-operative, okay, then your post-operative. Post-operative is usually, if you see it, look at the appendectomy, polycystectomy, they're kind of all same, depending upon if it's a laparoscopy, if it's an open surgery, okay, and your complication will be mostly same, okay. But here, only thing you focus it, if it's abdominal surgery, you focus on GI assessment. If it's a renal, you more focus on your renal assessment, okay. Then post-operative also immunosuppressive therapy. So you will be giving them education on prevention of infection. Don't go into the big, huge crowds, okay, because they are more prone to infection. And if they are on steroids, they have to watch their weight. They have to watch for fluid volume excess, because that's what steroids do. And the other important thing, if somebody is on steroid, they might have to modify their diet, okay? So they have to be on the healthy diet because they don't want to put on the weight too much. So the other thing is you have to look for complementary health approaches, okay? When we talk about complementary health approaches, we don't do just for chronic kidney. We also do some of the things that psychosocial comes with their chronic disease. Okay? Think about that, any patient, if it's acute, we know that it's going to get better. Okay? Chronic, you don't know. It's going to get worse and worse and worse. Think from that point of view, if somebody tells you that you're not going to get cured from this unless you get a new kidney. So that's why you have to do a lot of palliative care, spiritual support, massage, dietary changes, okay? And then also some of the stuff, like I said, salt substitute, okay? Eggs, they cannot have it, okay? Or some of the herbs, they take it, they're not good for kidneys. So you need to know everything the person takes. Even over-the-counter, vitamins, minerals, anything they take it, you need to know. So nursing process, it always starts with prevention. Okay, whenever you start our nursing process for intervention, prevention is our first, then you do the screening, and third is the tertiary. So these ones we all discuss about in our prevention. If somebody has a diabetes, high blood pressure, we already start saying that you are at the risk for kidney disease. Let's start controlling your diabetes, let's start controlling your high blood pressure, start watching your diet. So those are the stuff that you start talking to the patient. So assessment, so typically you're looking for clinical manifestation of chronic kidney disease, okay? And also any other disease that you think contributed to the kidney disease. So here, look at that, we are looking at fistula, gall tone, depending upon what access the person is, or if the person is on peritoneal dialysis, or is on a hemodialysis, okay? So your physical assessment changes. The top one stays same, no matter what condition they are on dialysis or not on dialysis. So tissue perfusion is our priority here, okay? And intake output, restrict fluid, because they might be in a fluid volume overload, they have polyuria, they are peeing less. Monitoring respiratory status. Okay, if you see that person is having some pulmonary implication from the kidney disease, they are having pulmonary edema, they are having shortness of breath, then respiratory becomes your priority. Airway and breathing rather than your tissue perfusion. Transfusion. For nutrition, I want you to follow the chart that I gave you for pre-dialysis and the peritoneal dialysis. That kind of tells you in a nutshell what kind of a diet you're supposed to be having. And you guys will be learning the foods for phosphate and potassium in other lectures, the student lecture, right? So you kind of know that which foods they need to be avoiding if they are on low potassium diet or if they are on low phosphorus diet, okay? And in what condition they can have low protein or in what condition they need a high protein. That's important too. Reduce risk for infection, especially if somebody has AD fistula, AD graft, central venous catheter or peritoneal, or even if somebody has a replacement catheter with a new kidney, they might have a site for infection. So here you see that we are all discussing our common things that we do to reduce infection. It's like we are not learning anything new, especially here, maybe you were watching for peritonitis. Antibody lineage. Very important in an end-stage renal disease when persons start having uremia. Okay. If you get a chance, or whenever you will remember that if you see a person who has a really bad uremia and who are on corticosteroids and all those fluid restrictions, their skin is really bad, and some people do develop body image problems, so you have to be very sensitive about these. Okay? And I have seen that I have a person, he went into a major depressive disorder when he diagnosed with a chronic kidney disease. I think he has a diabetes, he has a high blood pressure, he was only 30 years. Okay, so that was a hard one. So he was on antidepressants too. So you have to, any chronic disease, it does not affect your physiological, economic, social, psychosocial, your whole life is kind of upside down because you have to live with that disease. Home care based on what kind of renal replacement therapy we are doing it. Okay? So basically if it's a pre-end stage renal disease, we are just going to talk about the diet, signs and symptoms of high potassium, high phosphate, okay? Telling them to keep their appointment, annual appointment or every 6-month appointment, okay? Because it is going to decrease function. You're going to monitor renal function every time they go. So, but if they are on peritoneal dialysis, you're going to include that in the discharge treatment. If they are on hemodialysis, you're going to give them that treatment. So that's based on home care is based on what type of renal replacement therapy they're getting. Okay. Any questions? So this is when you're trying to compare. So think about these points. When you're trying to compare hemodialysis, peritoneal, and transplant